This is a 32-year-old patient with anterior knee pain, and we see the classical findings of edematous changes in the proximal patellar tendon. There are more intense high signal changes where the patellar tendon attaches on the inferior pole of the patella. There is edema at the inferior pole of the patella, and there are adjoining soft tissue edematous changes projecting in the Hoffa's fat pad. So this is the patellar tendon, patella, quadriceps tendon, and overall we see features of marked proximal patellar tendinopathy with small partial tear in the deep fibers. These changes are also well seen on the axial images, so let's look at them. Looking at the axial images, so we have this is the patellar articular cartilage coming to the proximal patellar tendon. This is the proximal patellar tendon. These are the deep central fibers of the patellar tendon where there are marked tendinopathic changes, and there is small partial tear in the deep fibers. There are soft tissue edematous changes projecting into the anterior Hoffa's fat pad. Now, the mainstay of the treatment for these patients is conservative, and that's very important. Sometimes non-steroidal anti-inflammatory medications, but when the symptoms are not settling, especially in active patients, then one has to consider injection treatment, which is sometimes in the form of dry needling, but increasingly nowadays we also perform PRP injection. Before that, let's look at the ultrasound appearances. So these are the ultrasound appearances. This is the inferior pole of the patella, proximal patellar tendon. This is the patellar tendon with normal appearances, typical normal linear fibrillar pattern, normal thickness. But as we approach the inferior pole of the patella where this attaches, this has lost its normal fibrillar pattern where there are diffuse hypoechoic changes and thickening in the patellar tendon. The next thing is we assess power Doppler, and on power Doppler we can see that there is marked increase in the neovascularity, which is abnormal. So in this case, there was a plan for PRP injection done, and the injection was performed. This is the needle coming from here, which is from the distal aspect, the needle piercing the patellar tendon, and then PRP is being injected immediately adjoining and into the area of the marked patellar tendinopathy. No steroid injection is performed, and ideally no steroid injection should be performed around the patellar tendon. Next, we try and understand what exactly is patellar tendinopathy. It is again an overuse injury. It is a chronic overuse injury. It is not something like an acute trauma. It is some form of overuse which is happening over a period of time, which leads to micro injury and then micro tears. It happens more commonly in athletes with jumping activities such as basketball, volleyball, sprinting, and it has another name which is called as jumper's knee because of that. So we already saw the MRI and ultrasound appearances. So on the MRI, we saw that there is presence of high signal change in the proximal middle deep fibers of the patellar tendon, and there may be presence of partial tears. We also noted that there was edema in the adjoining Hoffa's fat pad. On ultrasound, we noted that there is thickening in the tendon, there is loss of normal fibrillar pattern, and there is neovascularity. So we have already seen the appearances on the MRI and on the ultrasound examination. This is the neovascularity.